Welcome to the deep dive. Today, we're tackling something, well, pretty fundamental. The core concepts that really underpin healthcare.
That's right.
Think of this as your essential guide to understanding what keeps the whole system running smoothly,
Exactly. We've waded through a pretty comprehensive review session. It covered a huge range of nursing topics.
Wow.
And our goal here is really to pull out the crucial stuff, the foundational knowledge that ensures, safe and effective patient care.
Okay. So for you, the learner listening in, this is going to be a focused yet hopefully quite complete overview. We'll be looking at everything from the ethical principles guiding professionals to the practical skills keeping patients safe. Okay, let's unpack this, starting with what the review calls the bedrock of nursing practice. The nursing process.
That's right. The nursing process, it's essentially the systematic roadmap nurses follow. It's the framework, really, that guides their actions and their decisions.
Got it, a framework. And building on that, the review jumps right into professional standards, sort of the ethical and legal compass, right?
Pretty much, yeah. That directs healthcare professionals. And there are quite a few key principles here.
Okay.
Starting with autonomy.
Autonomy. What's the core idea there?
Autonomy is, well, it's a cornerstone of patient rights. It just means that a patient has the power to make their own decisions about their health, their medical treatment.
Their own decisions?
Yeah, including the right to say yes, but just as importantly, the right to refuse or even stop a treatment that's already started. It's all about respecting their independence, their right to self-determination.
Right, self-determination. And closely related seems to be beneficence?
Beneficence, yes. That's the ethical principle of actively working for the benefit of others.
So doing good.
Basically. In healthcare, it means always striving to do good for the patient, promoting their well-being.
Okay. Then we have non-maleficence. That sounds a bit formal.
It does sound formal, but it's really powerful principle. Non-maleficence simply means to do no harm.
Do no harm.
Exactly. It guides professionals to think carefully about potential negative consequences of their actions and will avoid anything that could hurt the patient.
Right. Makes sense. And then there's justice. This feels like it goes beyond just one patient.
Absolutely. Justice in healthcare, it's about fairness and equity.
Yeah.
Especially in how healthcare resources are distributed.
Resources.
It means trying hard to make sure all patients get the care they need, regardless of their background or circumstances.
Fidelity is another one mentioned. What does that look like day to day?
Fidelity is really about being loyal, keeping your promises to your patients.
Keeping promises.
Yes. And it also implies a deep commitment to their care, like a nurse's dedication not to abandon a patient, even when things get tough.
And advocacy, we hear that term a lot. The nurse as an advocate.
Exactly. Advocacy just means actively supporting your patient's best interests. The nurse's primary loyalty, their responsibility, is to the patient. Whether that's one person, their family, or even the community, you speak up for them.
Okay. Now, the review also flags responsibility. Sounds like there are a few layers to that one.
There are. Responsibility means, well, you're obligated to perform your duties, your tasks. In nursing, this means being accountable for your own actions, sure, but also making sure tasks you delegate to others are done right.
Delegation too.
Yes. And crucially, it also means having the knowledge and the courage to question orders that seem wrong or maybe unsafe. And, having a solid grasp of pharmacology, how drugs work, interactions, dosages, all that.
An accountability that ties in closely with responsibility, but it's slightly different, isn't it? More about the outcome.
Precisely. Accountability is about accepting ownership for the results of your actions, or even for not acting when you should have. You're answerable for the care you provide.
Confidentiality. That's something we all kind of expect, right?
Oh, absolutely. It's a fundamental ethical duty. Confidentiality means protecting a patient's personal info, their medical details, from anyone who isn't authorized to see it. It's built on respecting their privacy and trust.
Okay. Moving on, the review mentions informed consent. When is that specifically needed?
Informed consent is basically required for any medical procedure or treatment. The person performing the procedure, the doctor, usually has the responsibility to make sure the patient understands everything involved.
Everything? Like what?
Like the risks, the potential benefits, any alternative options, all before the patient agrees to go ahead.
Okay. Now, this next part seems really important for legal boundaries. The difference between assault and battery. It's not just physical hitting, is it?
Not at all. Assault is defined as any action that makes someone fear immediate, harmful, or offensive contact. It doesn't even need physical touch.
Just the threat.
Essentially, yes. Battery, on the other hand, is the actual intentional touching of someone without their consent or, legal justification. So you can have assault without battery and vice versa.
Interesting distinction. And for communication words, we have slander and libel. How do they differ?
Slander is when someone makes false spoken statements about another person that hurt their reputation.
Spoken. Got it.
And libel is the written version of that, publishing false statements that damage someone's reputation.
Okay. Then there are negligence and malpractice, terms you hope not to hear often in healthcare.
Definitely. Negligence is essentially failing to provide the level of care that a reasonably careful person would in a similar situation.
Then malpractice.
Malpractice is a specific kind of negligence committed by a professional, like a doctor or nurse, someone with specialized knowledge. It means they breached the professional standard of care, and that breach resulted in harm to the patient.
Okay, that's a heavy but important set of standards. Let's shift gears a bit. Something maybe less technical but absolutely vital. Therapeutic communication. The review highlights the importance of something that might feel awkward. Silence.
Oh, yeah. What's fascinating here is the incredible power of silence, especially in healthcare. It gives patients that crucial pause to gather thoughts, process tough emotions like sadness or grief, and figure out what they want to say next. It's not just empty space. It's an active part of communicating.
The review also mentions providing presence. What does that really mean in practice?
Providing presence, it's more than just being physically there. It means being fully attentive, like physically and emotionally.
Fully there.
Yeah. Showing empathy, offering support without necessarily needing words, just letting the patient know you are truly there for them in that moment.
Okay. When communicating with patients who have hearing impairments, what are some practical tips?
The review points out a few key things. First, try to cut down background noise as much as possible.
Good point.
Speak clearly. Normal volume shouting can actually distort sounds and make it harder. And critically, don't just assume they understood because they nod. Always confirm understanding. Maybe ask them to repeat it back or explain it themselves.
Good advice. And for patients with visual impairments, how do we adjust?
When you approach someone visually impaired, always identify yourself clearly. Say who you are, what you do.
Makes sense.
Also, make sure the lighting is good, helps maximize any vision they might have. And describe things, their surroundings, procedures you're about to do. Be their eyes, in a way.
Communicating with cognitively impaired patients needs a different approach, too. Simpler is better.
Exactly. Use simple, direct sentences. Avoid long, complex explanations or, abstract ideas. Focus on one thing at a time and be ready to repeat yourself patiently.
What about patients who've had a stroke? They might struggle with language, right?
Yes. Simple yes-no questions can be a great starting point. Use communication aids if you have them. Picture boards, writing tablets, gestures work too.
Nonverbal cues.
Exactly. And most importantly, be patient. Give them plenty of time to process and respond. Don't rush them.
Finally, communicating with unresponsive patients. Is there still a point?
Absolutely. Even if someone seems unresponsive, keep talking to them. Use verbal communication, gentle touch. Explain everything you're doing before you do it. Orient them. Tell them their name, where they are, the time. You just never know what they might be hearing or sensing.
Okay, let's move to another cornerstone. Documentation. Charting. The review really hammers home sticking to facts, being objective. Why is that so vital?
Accurate, objective documentation is, it's paramount. It provides a clear, reliable record of the patient's condition, the care they got, how they responded.
Or a reliable record.
Yes, and this info is vital for the whole healthcare team. Ensures continuity of care, patient safety. It's the communication hub, really.
The review warns against using vague terms. Why is being precise so important here?
Vague terms like appears comfortable or seems anxious. They're subjective, open to interpretation. They don't give concrete info.
Right.
It's much better to describe exactly what you see. Instead of appears comfortable, maybe document patient resting quietly, breathing evenly. Clearer picture.
And instead of interpreting behavior, describe the behavior itself. Can you give an example?
Sure. Instead of writing patient agitated and combative, which is your interpretation.
Right, that's a label.
Exactly. A more objective description would be patient yelling loudly, attempting to push staff away, kicking at side rails. See, specific, observable actions anyone can understand.
What about subjective data, what the patient tells you? How do you chart that accurately?
Best practice. Use direct quotes whenever you can. If a patient says, "My pain feels like a burning in my chest," You document exactly that, in quotes.
Ah, preserves your voice.
Precisely. Captures their specific experience.
Accuracy just keeps coming up as essential in documentation.
Absolutely. Non-negotiable. Recording vital signs, measurements, use the exact values. Don't say good urine output. Document the precise amount in milliliters. That detail can be crucial for spotting trends or problems early.
The review also says avoid unnecessary words, irrelevant details. Why the focus on being concise?
Clear, concise notes make it easier for everyone to find the info they need quickly. Extra stuff just clutters the chart, hides the important bits, could lead to delays or mistakes.
Incorrect spelling, using approved abbreviations. Seems small, but I guess it matters.
Oh, it matters hugely. Correct spelling and using only facility-approved abbreviations are essential to stop misinterpretations. Imagine a misspelled drug name or an abbreviation someone doesn't know could lead to serious errors.
Completeness is another key element. What needs to be included?
Completeness means documenting all essential info about the patient's condition, the care given, their responses. Often involves using flow sheets, graphic records for routine stuff like vitals, meds, pain levels. Make sure nothing gets missed.
The review stresses documentation needs to be current, timely. What happens if charting is delayed?
Documenting as close to the time of care as possible is vital for accuracy. If you wait, details get forgotten, inaccuracies creep in. That compromises patient safety, continuity. Timely charting means the whole team has the latest info.
Finally, the review mentions military time being common. Why that format?
Yeah, many places use military time, the 24-hour clock. It just eliminates any confusion between AM and PM.
Yeah.
Reduces the risk of errors, especially with medication times.
Okay. Let's shift to something more specific, sometimes overlooked. Sexuality and older adults. The review raises maybe a surprising point about STI risk.
It's a really important point, actually. Because pregnancy often isn't a concern anymore for older adults, there can be less awareness, maybe a lower perceived need for protection.
Right.
And that, unfortunately, can mean an increased risk of sexually transmitted infections.
And it seems older adults might be reluctant to discuss sexual health problems with doctors or nurses. Why is that?
Could be several reasons. Some might feel embarrassed or think sexual issues aren't important at their age. Maybe they worry providers won't take them seriously. So it's really crucial for healthcare professionals to create a comfortable, non-judgmental space to encourage those conversations.
The review also notes that when older adults do have physical issues affecting sex, it's often related to illnesses or medication side effects.
That's a huge factor, yes. Many chronic illnesses and tons of medications can directly impact sexual function. So providers need to assess for those underlying causes when talking about sexual health with older patients.
Okay. Moving to faith, hope, and religion often intertwine concepts. The review gives distinct definitions. Let's start with faith. What makes it distinct?
Faith, in this context, is defined as like a confident belief in something even without concrete proof. It's a conviction, a trust that goes beyond what you can see or measure.
And hope, how's that different?
Hope is more about anticipation, a belief in a positive future. It's having something to look forward to, something that gives life meaning, purpose.
Okay. And finally, religion. How does that fit?
Religion is described as more of a structured system, beliefs, practices, often involving worship, rituals. It typically gives a framework for understanding the world, morality, your place in things.
Right. The review then briefly mentions loss, death, and grief, pointing to other resources. We won't dive deep now, but obviously critical in healthcare. We encourage you, the learner, to check those out if it's relevant.
Definitely.
Now let's talk practical stuff. Infection control. Specifically, isolation precautions. There isn't just one kind, is there?
No, definitely not. Understanding how infections spread is key to picking the right precautions. The review outlines 4 main types: airborne, droplet, contact, and standard. Each one targets a specific way germs travel.
Let's start with airborne. What infections need this, and what are the key measures?
Airborne precautions are for germs that spread through tiny particles floating in the air for a long time. Think TB or measles.
Tiny particles.
Exactly. These patients need a private room with negative air pressure, keeps the air from flowing out. Healthcare workers going in must wear a special N95 respirator mask to filter those particles.
And N95.
Yes. And if the patient has to leave the room, they should wear a regular surgical mask.
Oh, okay. What about droplet precautions? Are the particles bigger here?
Yes. Droplet precautions are for infections spread by larger respiratory droplets from coughing, sneezing, talking, like influenza or pertussis. These droplets usually travel only about 3 feet.
3 feet.
Right. So healthcare workers need a surgical mask when they're within that distance. And again, the patient wears a surgical mask if they leave the room.
And contact precautions, when are those used?
Contact precautions are for germs spread by direct touch touching the patient or indirect touch touching contaminated surfaces. Think MRSA or C, diff.
Okay.
This means gloves when you enter the room, if you might touch the patient or things in the room, and a gown if you expect significant contact. Good hand hygiene before leaving is critical too.
Finally, standard precautions. These are the baseline for everyone.
Exactly. Standard precautions are the basic infection control practices used with all patients, no matter their known infection status.
Assume everyone could be infectious.
Sort of, yeah. It's based on the principle that all blood, body fluids, broken skin, mucous membranes might contain infectious agents. So it includes things like meticulous hand hygiene, using PPE gloves, gowns, masks when there's a risk of exposure, and handling sharps and contaminated stuff properly. It's the foundation.
Got it. The review then moves to surgical asepsis, or sterile technique. This sounds very precise, like unforgiving rules. Why so strict?
Maintaining sterility during invasive procedures is absolutely critical. It prevents surgical site infections, which can be devastating. Surgical asepsis aims to eliminate all microorganisms from the surgical area. The review lists several key principles.
Okay, let's walk through them. First one, sterile objects touching other things.
A sterile object only stays sterile if it touches another sterile object. If anything non-sterile touches it, boom, it's contaminated. Can't use it.
Second principle, what goes on a sterile field?
Only sterile objects. Anything non-sterile contaminates the whole field.
Third one involves seeing it and keeping it up high.
Right. If a sterile object or field goes out of your line of sight, or if you hold a sterile object below your waist, it's considered contaminated.
Why below the waist?
Because you can't be sure it hasn't touched something non-sterile if you can't see it, and below the waist is generally considered a non-sterile area.
The review also mentions air exposure, just being out in the air too long.
Yeah, prolonged exposure can let airborne microorganisms settle on a sterile object or field, contaminating it. That's why sterile stuff is packaged and opened right before use.
And moisture can be bad too. How does that work?
Yes, if a sterile surface touches a wet, contaminated surface, germs can wick up through the moisture like water up a paper towel. Capillary action. Also, gravity pulls fluids down, potentially carrying contaminants.
Finally, the edges of a sterile field or container aren't sterile. Why that specific border?
Typically, a 1-inch border around the edge is considered contaminated because those edges are just more likely to get touched or exposed during setup.
Okay, very precise. Let's move to a fundamental vital sign, temperature. The review gives the normal range, Celsius and Fahrenheit. What should we know?
The average normal oral temp for an adult is around 37 Celsius, 98.6 Fahrenheit. But the normal range is generally 36 to 38 Celsius, or about 96.8 to 100.4 Fahrenheit. Important to remember these are averages. Individuals vary slightly.
And how we measure it affects the reading too, right?
Definitely. The site matters. Rectal temps are usually about half a degree Celsius or almost a degree Fahrenheit higher than oral. Armpit temps are usually a bit lower.
Interesting that age plays a role too. Older adults?
That's right. Older adults often have a slightly lower average body temp compared to younger adults. So you need to keep that in mind when checking for fever in older folks. A temp that seems normal for a younger person might actually be a significant fever for someone older.
The review then lists a bunch of nursing interventions for fever. It's more than just Tylenol, isn't it?
Oh, absolutely. Managing fever is multifaceted. First, keep monitoring vitals, intake, output check for dehydration, look at their skin color, temp, check relevant lab results.
Okay.
For comfort, adjust bedding, take off blankets if they're hot, add them if they're shivering, encourage fluids, lots of them like 2,500, 3,000 milliliters a day, unless there's a reason not to. Give fever-reducing meds as ordered.
Right.
Encourage rest, limit activity. A tepid, not cold bath can sometimes help lower temp via conduction, but watch out for shivering, which actually raises temp. And if they're disoriented from the fever, safety precautions are key.
Fire safety. Hopefully never needed, but crucial to know. The review reminds us of Hesi. Break that down.
Sure. Hesi is a key memory aid for fires. Rescue get patients out of immediate danger. Alarm activate the fire alarm. Contain closed doors and windows to slow the spread of smoke and fire. Extinguish if the fire is small and you're trained. Try to put it out with an extinguisher.
RACE. Got it. Restraints. Serious intervention. The review says last resort only. Why?
Because restraints carry risks, both physical and psychological. They should only be used when all other, less restrictive methods have failed to keep the patient or others safe.
And you need an order.
Always need a physician's order specifying the type, the duration, and, critically, never attach them to movable parts of the bed, like side rails. That's dangerous.
How often check them?
Patients in restraints need frequent monitoring. The restraints must be removed at least every 2 hours for range of motion exercises, checking skin, circulation.
Basic skincare. Seems simple, but so important for preventing breakdown. Key points from the review.
Yeah, key points are avoid bathing too often, especially with hot water. It dries out the skin. Use mild cleansers. Always apply moisturizers after bathing.
Moisturize.
Definitely. Clean skin regularly, especially after incontinence. And don't forget, lips. Lubricate dry lips to prevent cracking and infection.
Sleep. Fundamental need. The review mentions things that disrupt it. Common culprits.
Oh, lots of things mess with sleep. Heavy meals close to bedtime. Stimulants like caffeine, nicotine, obvious ones. Even the environment room, too bright, too noisy. TVs in the bedroom.
Obstructive sleep apnea, OSA, also mentioned. Major risk factors and symptoms. And what's the priority assessment?
Main risk factors for OSA are obesity and hypertension. Common symptoms: loud snoring, maybe pauses in breathing, then gasps, feeling super sleepy during the day.
In the priority assessment.
Respiratory status. Check their breathing pattern, oxygen saturation levels. That's key.
The review also has tips for promoting healthy sleep, starting with the environment.
Yeah, create a good sleep space. Comfortable mattress, cool room temp, minimize noise and light, maybe a nightlight for safety if needed, especially for older adults or babies.
And bedtime routines. What's suggested?
A consistent routine helps signal your body it's time to wind down. Avoid stimulating stuff right before bed, intense shows, work. Try to associate bed mainly with sleep and sex.
Right.
Keep a regular sleep-wake schedule, even weekends. Stress reduction helps deep breathing, meditation. If you can't sleep after 15:30 means, get up, do something quiet and relaxing in dim light until sleepy.
Snacks. Caffeine.
A light snack, maybe dairy with tryptophan, might help some, but avoid heavy meals. And definitely avoid caffeine and alcohol near bedtime. They disrupt sleep later on.
Okay. Nasogastric tubes, NG tubes. Once it's in, how do you know it's in the right place before using it?
The gold standard, most reliable way, is an X-ray. It clearly shows the tube's tip position.
Not just checking stomach contents.
Checking the pH of stomach aspirate can give an initial clue, suggests it's likely in the stomach, but it's not foolproof. X-ray confirmation is essential before feeding or giving meds through it.
Gotcha. Total parenteral nutrition, TPN. Potential complications are listed. Catheter sepsis is one. How prevent that infection risk?
Strict sterile technique during insertion and care of the central line is crucial. The TPN tubing and bag should be changed every 24 hours. And if lipids are running, they shouldn't hang longer than 12 hours, reduces bacterial growth risk.
Hyperglycemia, high blood sugar, is another risk. How is that managed?
Yeah, TPN is high in glucose, so blood sugar needs frequent checks, usually every 6 hours. If levels are too high, insulin might be needed based on doctor's orders to keep it in range.
Fluid overload, also a risk. Signs a patient might have too much fluid.
Watch for sudden weight gain, swelling in ankles or lower back, dependent edema, bulging neck veins, crackles in the lungs when you listen. Those are signs of fluid volume excess.
What about the opposite? Suddenly stopping TPN can cause low blood sugar, hypoglycemia. What's done then?
Right. If TPN has to be stopped abruptly, there should be an order to infuse a 10% dextrose solution at a set rate. This prevents that sudden blood sugar drop.
Finally, air embolism. Rare but serious risk with central lines for TPN. How prevents air getting in?
Proper technique during insertion and removal is vital. Having the patient do the Valsalva maneuver, bear down, during removal helps increase chest pressure, prevents air entry, and properly clamping the catheter when not in use.
Okay, let's shift to urinary elimination. First up, urinary retention. Key physical finding.
The key sign is bladder distension. You might feel a firm, rounded bulge in the lower abdomen above the pubic bone. That's a full bladder if they can't empty.
What about signs of a lower UTI, urinary tract infection?
Typical signs are dysuria, painful or burning urination, urgency, frequency feeling like you have to go now and often. Urine might look cloudy or smell foul. And importantly, in older adults, sudden confusion can be the first or only sign.
Good point about confusion. Patient education for a healthy bladder. What advice?
Encourage drinking enough fluids, maybe 6 to 8 glasses of water daily. Advise limiting or avoiding bladder irritants like caffeine and alcohol. Avoid lots of fluids right before bed. And encourage regular voiding every 3 to 4 hours. Don't hold it too long.
Practical tips to prevent UTIs.
Teach proper hygiene wipe front to back. Advise women to void after intercourse. Avoid harsh soaps, bubble baths. Cotton underwear helps keep things dry. And some find cranberry juice helpful, though evidence varies.
Urinary incontinence can be distressing, but the review mentions it can cause skin breakdown. Why?
Yeah, prolonged skin exposure to urine causes irritation, redness, makes it more prone to breakdown and infection. Moisture and urine chemicals do that.
The review breaks down different types of incontinence. Let's start with transient characteristics.
Transient means temporary, often sudden onset, usually caused by a reversible medical issue like a UTI, constipation, side effect of a med. Treat the cause, the incontinence usually goes away.
Functional incontinence, what causes that?
Functional is when the urinary system works fine, but the person has cognitive, sensory, or mobility issues, stopping them from getting to the toilet in time.
Like dementia or severe arthritis?
Exactly. For these folks, scheduled toileting like every 2 to 3 hours can really help.
Stress incontinence, often linked to exertion.
Yes. Happens with sudden pressure, increased coughing, laughing, lifting. Pelvic floor muscles can't hold back the urine. Kegel exercises to strengthen those muscles are key here.
Urge incontinence, that sudden, intense need to go.
Right. A sudden, strong urge you can't delay often leads to leaks, associated with overactive bladder. Management includes avoiding irritants, bladder training gradually increasing time between voids.
Lastly, reflex incontinence, often neurological.
Yes, usually due to nerve damage controlling the bladder, like from a spinal cord injury. The bladder empties involuntarily without the person feeling the urge. Intermittent catheterization is often used to manage this.
Okay, let's move down to bowel elimination. Lots of factors influence our habits, the review says.
Oh, yeah. Age, diet need enough fluid, 2,000, 3,000 milliliters daily, plus fiber, activity levels, psychological stuff like stress, personal habits, positioning for defecation, pain, pregnancy, surgery, anesthesia.
Surgery, paralytic ileus.
Right. The bowel can temporarily stop working for 24, 48 hours after abdominal surgery. And medications, of course, lots of meds affect bowels.
Constipation, common problem. How's it defined and what causes it?
Defined as less than 3 bowel movements a week. Hard, dry, difficult to pass. Common causes: low fiber fluid diet, lack of exercise, medication side effects. Dehydration makes it worse. Look for dry skin, dark urine, low output, poor skin turgor, fatigue, dizziness.
Teaching healthy bowel habits. Key recommendations.
Establish a routine. Often the urge is strongest about an hour after eating. Provide easy access to bedpan or bathroom. Privacy is important. Keep call light tissue nearby. Stand near fall risk patients. An elevated toilet seat can help those who have trouble sitting.
Digital removal of stool, mentioned as a last resort. Considerations and risks.
Only after other methods fail. It's uncomfortable, distressing. Risks include irritating or bleeding the rectal lining, and vagal stimulation can cause bradycardia, slow heart rate. Absolutely needs a provider's order.
Ostomy care, fundamentals for managing the pouch and stoma.
Empty pouches when they're about 13 to 12 full. Change the whole system every 3-7 days, depends on the type. Clean skin around the stoma gently with warm water. Avoid soap. Check the stoma each time should be pink or red, moist. Look at the skin for irritation.
Diet restrictions, colostomy versus ileostomy.
Generally, no specific diet restrictions for colostomies. But ileostomies lose more fluid and salt because digestion isn't complete, so patients need to replace those to avoid dehydration.
Okay, let's talk oxygenation. Vital process. The review covers hypo and hyperventilation. Start with hypoventilation. What happens? Causes. Signs.
Hypoventilation is breathing too slow or shallow. CO2 builds up in the blood.
Yeah.
Signs: mental status changes like confusion, drowsiness, maybe cardiac arrhythmias, even cardiac arrest. Causes: CNS depressant drugs, neuromuscular diseases, broken ribs, making breathing painful.
And hyperventilation. Breathing too fast. Signs.
Yeah, rapid, deep breathing, blowing off too much CO2. Symptoms: numbness, tingling in hands, feet, lightheadedness, maybe loss of consciousness. Causes: anxiety, infection, drugs, acid-base imbalance.
Hypoxia. Not enough oxygen to tissues. What SpO2 level indicates it? Early versus late signs.
Hypoxia is inadequate tissue oxygen. Generally, PO2 below 95% raises concern. Early signs can be subtle: anxiety, restlessness, can't lie flat comfortably, increased heart rate, respiratory rate, BP bodies compensating.
And late signs?
Late signs are more severe: confusion, cyanosis, that bluish color in lips, mucous membranes, tongue. Causes are varied: anemia, CO poisoning, lung issues like edema or pneumonia, anesthesia effects.
Suctioning to clear airways, oral pharyngeal versus tracheostomy suctioning. Key difference in technique.
Oral pharyngeal suction in clearing mouth throat is a clean procedure. Non-sterile gloves usually fine. Tracheostomy suctioning going into the trachea needs sterile technique to prevent lower respiratory infection.
Anything else for tract sectioning?
Yes, hyperoxygenate the patient first. Apply suction 120-150 mmHg Hg, only when pulling the catheter out, not going in. Rotate the catheter gently. Limit the whole pass to less than 10 seconds.
Pain, complex. The review contrasts acute and chronic. Key differences.
Acute pain. Usually sudden onset, clear cause, limited duration. Often triggers physiological signs, faster heart rate, higher BP, fear, anxiety. Chronic pain. Persists, often 3+ months. Cause might be unclear. Leads to depression, fatigue, hopelessness. Really affects quality of life.
Pain management approaches meds and non-meds. Examples?
Meds include opioids, NSAIDs, some antidepressants, anticonvulsants, muscle relaxants. Non-med approaches, 10S units, heat-cold, distraction, relaxation, biofeedback massage, acupuncture. Often a combo works best.
Crutch walking. Different gaits mentioned. 4-point gait, when used.
4-point is very stable, needs weight bearing on both legs. It's slower, sequence, right crutch, left foot, left crutch, right foot.
3-point gait, for non-weight bearing on one leg.
Right. Move both crutches and the bad leg forward together, then swing the good leg forward.
2-point gait, partial weight bearing each foot. How's it different?
2-point is faster, more like natural walking. Move one crutch and the opposite leg together, then the other crutch and its opposite leg.
Cruising through gait.
Often used by people with paralysis, using braces. Both crutches forward, then swing both legs through, often landing ahead of the crutches.
And stairs with crutches. Rule of thumb.
Simple one. Up with the good, down with the bad. Going up. Lead with strong leg, then bring crutches and weaker leg up. Going down. Lead with crutches and weaker leg, then bring strong leg down.
Pressure ulcers. Big concern, especially for immobile patients. Contributing factors.
Several things increase risk. Altered sensation, can't feel pressure. Immobility, can't shift weight. Confusion, can't communicate discomfort. Shear force skin stays put. Tissue underneath moves, damages vessels, friction rubbing on sheets, and moisture incontinence, sweat softens skin, makes it vulnerable. Prolonged moisture is bad.
Serious wound complications, dehiscence and evisceration. Difference, what to do immediately.
Dehiscence is partial or total separation of wound layers. More common in abdominal wounds, especially after coughing, vomiting. Teach patients to splint incision with a pillow. Evisceration is way more serious organs protrude through the separated wound.
Evisceration is an emergency.
Absolute emergency. Cover protruding organs immediately with sterile gauze soaked in sterile saline. Notify surgical team stat. Keep patient NPO. Watch for shock. Prepare for surgery.
Nutrition for wound healing. Key nutrients. How assess protein status?
Need good nutrition. Vitamins A and C are important. Enough calories for energy. And adequate protein, the building blocks. Collagen is protein. Check serum albumin, prealbumin levels to assess protein status. Low levels impair healing. General goal, 30-35 kilocalorie day for protein.
Medication administration guidelines. Critical one. Never give a med someone else prepared. Why? Absolutely not.
Cornerstone of safety. You, the administering nurse, are the final check. You must verify the rights like patient, drug, dose, route, time. If someone else draws it up, you lose that check. Increases error risk hugely. You're accountable.
Patients can refuse meds. What should the nurse do?
First, find out why. Misunderstanding, side effects, beliefs. Understand their concern. Then educate clearly about the med, why it's needed, risks of not taking it. Document the refusal, the reason, the education, and notify the provider.
Ethical principle. Never deceive a patient about meds, with one tiny exception.
Honesty and trust are key. Always be truthful about meds. The only exception is a fully disclosed research study where deception might be part of the protocol and the patient gave informed consent knowing that possibility. Otherwise, always be honest.
Can all tablets be broken or crushed?
Definitely not. Only break scored tablets if appropriate. Never crush and tear coded sustained release, SR, or extended release, XR meds. It ruins the formulation, can cause dose dumping dangerous. Always check with pharmacy first.
Transdermal patches, key steps for applying.
Gloves on first. Avoid touching the med. Remove old patch. Dispose properly. Rotate sites. Use clean, dry, intact, hairless skin arm, chest, upper back usually. Press firmly.
Ear drops. Different technique for adults versus young kids. Pulling the ear.
Yes. Direction matters to straighten the ear canal. Adult kids over 3. Pull auricle up and back. Kids under 3. Pull auricle down and back.
Eye drops. Proper technique.
Head tilted back. Look up. Pull down lower lid. Gently create conjunctival sac. Drop into the sac center. Don't touch the eyelid with dropper. Gentle pressure on inner canthus after drops helps prevent systemic absorption.
Eye ointment. How's that different?
Look up. Pull down lower lid. Squeeze thin ribbon along lower lid, inner to outer canthus. Close eye gently. Vision might blur briefly.
Rectal meds, preferred position, insertion depth.
Sims position, left side lying, upper knee flexed, usually best. Water-soluble lubricant on suppository tip.
Oh.
Adults insert about 4 inches. Child, infant, about 2 inches past the sphincter.
Intradermal injections like TB tests. Key technique points.
No aspiration. Shallow angle, 10-15 degrees, bevel up. Inject slowly, look for a wheal or bleb forming. Max volume, usually 0.1 LELA. Short, fine needle, 38-inch, 25-27 gauge.
Intramuscular IM injections, always aspirate.
General guidelines say aspirate for most IMs to check for blood vessel entry, but the review notes aspiration is not recommended for vaccines now. Always follow current guidelines, facility policy.
IM sites. Needle sizes, length.
For 2 ml ventral gluteal, hip, vastus lateralis, thigh, preferred in adults. Deltoid, arm for vaccines, smaller volume, shorter needle, maybe 58-inch, 23-25 gauge. Insulin, sub-Q, really. Max 1 ml, short thin needle, 38-inch, 29G, 45-90 degrees. Other general IMs, 1 to 1.5-inch needle, 90 degrees, depends on patient size, muscle, med viscosity.
Finally, IV therapy complications, key ones to watch for.
Common ones: circulatory overload, too much fluid too fast, infiltration, fluid leaks into tissue, swelling, cool, phlebitis, vein inflammation, pain, redness, warmth, cord-like feel.
The review ends with fluid imbalances, deficit and excess, key signs for each.
Fluid volume deficit, sudden weight loss, postural hypotension, BP drops when standing, tachycardia, fast heart rate, dark concentrated urine, fluid volume excess, sudden weight gain, dependent edema, swelling, full neck veins, crackles in lungs.
Wow, okay. That was truly a deep dive into a really comprehensive set of fundamental healthcare concepts. It's quite remarkable seeing how all these pieces, ethics, communication, technical skills like meds, they all interconnect, don't they?
They really do. And what's truly fascinating, I think, is realizing that quality patient care isn't just a list of tasks. It really requires that strong ethical compass, the ability to connect and communicate effectively with all kinds of people. Meticulous attention to detail in everything from charting to sterile technique, and just a deep understanding of what's actually happening physiologically.
So for you, the learner, listening in as you've navigated this with us, maybe think about how understanding these foundational principles gives you a new lens, whether you're thinking about a healthcare career, supporting someone, or just want to be more informed.
Yeah.
What specific area that we covered today really sparked your curiosity? What further questions might you have now about this incredibly intricate world of healthcare?